joined by our guest speaker, Karin Neufeld, who is a professor and Morgan Firestone Chair of the Department of Psychiatry and Behavioral Neurosciences. She'll be focusing her presentation today on what we know about delirium and why it is important to prevent and treat early if it occurs, particularly as it relates to older adults. Just a few housekeeping items before we get started. This public lecture today will be recorded, so please just ensure that you are muted for the duration of this presentation, just to eliminate any background noise. As well, we will opt to leave questions for the end of the presentation. So please feel free at any time to leave your questions in the chat, or if you prefer to save them for the end, whichever you prefer is great. Where you'll have an opportunity to ask them. So thank you so much, Karin, for taking the time out of your busy schedule for speaking to us about delirium. And without further ado, I will pass it off to you.
Great. Thank you so much, Catherine, for the kind welcome, and to Kate for helping with all the technical aspects of this public lecture. Today, as announced, I'd really like to talk about something that I have spent a good bit of my career thinking about, and also caring for patients with this condition, at least in my previous existence. You'll see a lot from Johns Hopkins University, and that's because I spent about 30 years of my career there working at the hospital and the medical school. And I've more recently come back to Canada. I am a Canadian. I have taken over the chair position here in the Department of Psychiatry and Behavioral Neurosciences at McMaster University. Delighted to be here, doing much less delirium work because I don't work in an ICU anymore. But I'm delighted to tell you about what I know, what little I know about it, and to really try to spark your imagination about the kinds of things that are yet to be done. So let's see if I can get my slides to work. I believe that I am sharing my slides, so let's see if that works. Great, excellent. So no disclosures of a financial nature that is going to influence what I say. I do want to let you know that I'm going to mention a little bit about antipsychotic medications, which are not FDA approved for the treatment of delirium, and I'll tell you why later. But I will be mentioning that. We always like to make sure that everybody is aware of what is and is not actually an approved treatment. But we'll talk much more about that later. So I'd like to get our ducks in a row, as it were. It's important that you understand what I'm trying to do with this introduction to delirium. First of all, I just want you to have a little bit of an understanding about what I'm referring to when I say delirium. I want you to understand why we should all care about delirium and its prevention. And I'd like to also introduce you to the things that seem to have most traction in terms of the prevention of delirium and how to treat it once it arises. So where shall we go first? And first, I'd like to actually go to ancient Greece, because believe it or not, 2,500 years ago, Hippocrates actually talked about delirium in a most convincing and remarkably consistent way as to the way we think about it today. So first of all, Hippocrates described in the Book of Epidemics conditions that he referred to as phrenitus and lethargus. And this ostensibly is something that we still talk about today. Phrenitus, frenetic movement or hyperactive. Lethargus, meaning hypoactive or somebody who's lethargic. Both of these are motor presentations of delirium that we still see, that we still refer to today, and can be the presentation of this syndrome. He described this as being a problem that develops relatively suddenly. So somebody can be in your baseline state of thinking and cognition, and all of a sudden, over the course of hours to days, develop a very profound problem. It's often associated with fever, is what Hippocrates noted, and this in fact is true. Of course, it can be associated with other things as well, and we can talk about that again, but very, very commonly, it seems to be associated with maybe an inflammatory response, particularly to infection. And it's characterized by problems with thinking and can be characterized by unusual behavior. And he also went on to say very clearly in this ancient text that it's often associated with problems with sleep and unstable moods. So our definitions today, I've amended these just to be a little briefer, but fundamentally pretty much what Hippocrates actually described. So we haven't come that far, but at least we've described it very consistently over the last 2,500 years. Again, delirium, we think, is fundamentally a disturbance in attention or awareness. So the ability to focus on something and be aware of your surroundings. It's, again, just as previously described, abrupt onset with symptoms that can fluctuate throughout the day, for example. It is characterized by new cognitive deficits. So something that the individual didn't experience the day before when they didn't have delirium. And I just want you to think about it. If you can't pay attention to something, it would be very difficult for you to learn new information, right? If you couldn't pay attention to where you got to in the day, you don't know, you don't remember coming into the hospital, for example, then you might be very disoriented, right? How did I get here? Why am I here? What's happened? Also, perceptual disturbances are prominent in delirium. So misunderstanding the things you see or the things you hear, or maybe even seeing things that aren't there, in fact. It, by definition, is not due to other neuropsychiatric disturbances, such as dementia. But I will say, for the purposes of this conversation especially, it is dementia that is one of the strongest risk factors for somebody to develop a delirium superimposed on dementia. So we'll come back to that. So it's not really a product of the dementia per se. This is a separate kind of syndrome that is due to some other physiologic cause. And I've already alluded to that. Maybe if you have a severe infection, or maybe just a urinary tract infection, maybe that's enough to stimulate a delirium to occur. So other features, just as Hippocrates noted, really are very common as well. And our group's experience in looking at the way that people present with delirium suggests that sleep-wake difficulties are almost always there. Even though it's not part of the definition, it's almost always there. So you might see that somebody's up all night and they're not sleeping at all, or they're not sleeping at all at night, but they're sleeping during the day. We call that day-night reversal in terms of sleep-wake rhythm. And it's the thought of some of us that maybe delirium actually represents a kind of sleep-wake disorder, that that's maybe one of the fundamental problems with the delirious brain. Again, not going to spend time on this, but just to demonstrate, this is very, very common. Emotional lability and irritability, just as Hippocrates also described in his book, also is very common. So even people who aren't by nature very irritable, certainly aren't impatient or difficult with their healthcare providers at baseline, may in a delirious state be acting very strangely and very irritably, or maybe very amorously. There's all sorts of things that can be quite disrupted in terms of a delirium and people's behavior. Also, as I've mentioned, people can hallucinate. That means seeing something that isn't there. So responding to a stimulus that isn't present. And so people can also misunderstand what's going on. So maybe the bed curtain beside the hospital bed can be seen as a figure or someone standing over them or some sort of frightening creature. People can also develop delusions, and I'm going to show you the example of a delusion in a few moments, if all goes well, with my ability to show a video. And a delusion is basically a fixed, false, idiosyncratic belief, which means it's something that is just a strange, false idea that gets lodged in somebody's head, and it's just almost impossible. It is impossible to argue them out of it. So that can occur also in this syndrome of delirium, which is not a disease per se, but is caused by some underlying physiologic problem. So, and again, phrenitis, lethargus, agitation or lethargy are both presentations that we can see when patients develop delirium. And you can imagine how a lethargic patient in the hospital won't even get noticed, because if they're just sleeping all day and they're not interacting with anybody, but they're really delirious, they really have all these cognitive changes, you can see how they might get missed unless we're actually looking for it and we're actually actively waking people up in the hospital during the day and making sure they're interacting with the environment. So Joanne is a patient of mine. She's 78 years of age. She had chronic kidney failure such that she was on hemodialysis, and she ended up requiring a kidney transplant, which was successful initially, but she ended up getting an infection and had to come back to the hospital, and all of a sudden became septic, meaning had just a very florid infection. Her kidney was infected. And she became very, very agitated and delirious in the intensive care unit. And such that she was extremely fearful and angry. This is completely out of character for Joanne. She's a lovely person, no problems with any difficulties in her life in terms of getting along with others. But during this episode, she was so violent. She's just a tiny little thing, so violent. She was biting and hitting staff and calling them names. And they couldn't understand what was going on. And in fact, one nurse was actually very badly injured when Joanne actually bit her hand, and she was out of work for quite some time. Nurses were terrified of her. And I know this doesn't speak very well of the nurses who were caring for her, but they didn't recognize that she was delirious. They really didn't understand. These were early days when we were really still doing a lot of work with our colleagues throughout the hospital to try to educate them about delirium, how to recognize it, how to screen for it. These were very early days, but they really didn't understand what was going on. And you can imagine how difficult it was for them as well to try to care for this combative patient who was so, so sick. The family didn't know what was happening. They were terrified. They had never seen their mother like this. They kept saying, "This is not my mother. Whatever is going on here, this is not my mother." And they were terrified. And it was several weeks later, she did get better, of course, and several weeks later, she asked to see me and my team because she was so frightened about what had happened to her. And she had learned about this nurse that had gotten very injured in caring for her, and she felt so terrible. She couldn't imagine how that had happened. And she really wanted to talk to somebody about it because it was so incredibly frightening. And so she agreed to do a video, and she gave me permission to show it to anybody for whom it might make a difference for them to understand about delirium. So let's see if we can hear from her. She's going to talk rather softly, and I didn't record it with the volume up high enough, I think. And so I'll just tell you, she's talking about her creatinine was going up, an indicator of kidney failure, and her doctor had told her to come back into the hospital. And so she talks about what she remembers of the experience and her impressions and advice for me.
My creatinine level from the kidney problem was high, and my doctor at home thought that I should come up and I have a biopsy done. And that's the last thing I remember. The next thing I knew, I was waking up having some very bad feelings and bad thoughts and wondering why I was there and not knowing how I got there. I remember when I was intubated that I was having delusions. Um, they were People weren't there. There were aliens there. There were good ones and there were bad ones, and I had a stone, a crystal, and I had to make sure that crystal got to the right person. And these things were trying to hold me from getting the stone to work. So I was go half of them were human, half alien, and I had to determine who was good and who was not good. And I wasn't fighting them. I was just trying to get the stone to where it's supposed to go. And there was a robot in it who, every time I would make a mistake, he would take me back to the beginning again and had to scan me again. And I had to go through the same process of trying to find out where I'm supposed to be and what I'm supposed to be doing. I know it didn't happen, but it was in my mind. And to me, something happens in your mind and you see it, it happened. Whether it happened physically or mentally, it happened. My biggest fear right now is not the procedure itself or the problem itself. It's the going through the nightmares. They're terrifying. They're no one should have to go through that. No one. Talk to them, take time to see what they're trying to say. Keep diary. I'm going to ask you about what went on, and I want someone to be able to tell me when. And it's better if it's written down, just soothing words, soft music, something soothing, because I'm probably fighting a battle in my brain.
All right. So we've heard from Joanne. And I think, it was, for me, it was a very compelling story about the, the sort of juxtaposition of what the staff were seeing on the outside and what the family was seeing on the outside and the inside, and how terrifying and difficult it was. And really the real suffering that it produced within the family, within the patient, and within the healthcare providers who were trying to save her life at that time. So let's just talk a little bit about where we find delirium. Now, I'm going to be talking to you about the hospital situation because I was the director of the psychiatry consult service at Johns Hopkins when I was doing a lot of this work. And so I'm talking to you about the hospital. But of course, we find delirium, especially when we're talking about people who already have cognitive problems and may have dementia or other kinds of neurocognitive difficulties. You can certainly see it in the household. You can certainly see it in other settings. In nursing homes, it's a big problem as well and can easily be overlooked for the reasons I was saying before. So it's not just the hospital that we find delirium. However, the hospital is a place where we find it a lot. And so I just wanted to show you the prevalence or the proportion of people who have experienced delirium during their hospital stay in these various places in the hospital. So intensive care unit, orthopedic surgery, and hospitalization on a general unit. You can see that the prevalence is actually seem to be much higher in the intensive care unit, but are pretty frequent in other places as well. And what I think is important to note is that the more serious the illness, the greater the risk of delirium. And that's probably a good rule of thumb. The more ill that the person is, the greater the likelihood that they will have a delirium. Also, this is work, again, quite old work, by a colleague who really kicked us off on the need to identify what are the factors that cause delirium. And her name is Sharon Inouye, and she's at Harvard. She actually did this work as part of her master's of her MPH degree after she had finished her geriatric residency. And this work, and I've paraphrased her publication for you, but basically, this is sort of an interaction between who you are and whether you're at risk, low risk or high risk for dementia, or for delirium, pardon me, and then all the bad things that can happen to you. And in this case, I'm talking about bad things that the hospital may do to you, or maybe the illness that you have. And so you can see from this graph that if you are somebody at low risk of delirium, doesn't seem to matter, at least in this population that Sharon actually published on. It doesn't really matter what we do to you. You're pretty resilient and you don't seem to develop delirium. But if you have more risk factors, the higher that you are as a person with personal risk factors for delirium, it takes relatively little then to make you delirious. So maybe nothing bad happening to you, you don't really develop delirium, but as these factors accumulate, your risk goes up pretty substantially. So it's really an interaction between who you are and the bad things that happen to you. So age, one of the things that you can't do anything about, it is something about you that you carry with you, that we carry with us. And so over the age of 65, the probability of developing a delirium is much, much higher. There's something really cool about this graph too. Of course, this is a study, one of my colleagues at Vanderbilt actually did this. But if you actually trace this back and you went through the ages back down to age of 0, 1, 2, 3, or 5 years of age, what you'd find is small children are also at very high risk of developing delirium. And that risk actually drops probably as our brains get myelinated and we get more resilient. That risk drops and then picks up again over the age of 65. So how old you are will in fact predict whether you get delirious, whether you're very young or you're older. Here's not going to speak about all of these, but it just shows you a little bit about the work that we have done over the past 15 years trying to understand all of these risk factors around delirium. And up here, this blue bar about premorbid factors are all the things that we are, the things that we can't really change in our history when we come to the hospital, but seem to predispose to delirium. The biggest factors being advanced age and having a pre-existing dementia absolutely puts you at higher risk for delirium, which is why this is probably an important talk for Alzheimer's Society interested folks. There are all sorts of other things that can happen to you that can also contribute. And like I said, the severity of illness and infection is probably one, just like Hippocrates talked about way back in 2,500 years ago. But there's all sorts of other things that we do in the hospital. We put people, we put all sorts of invasive devices on people so that they can't move out of their bed. So we tell them to stay in bed. As you're going to hear from me later, it's probably one of the worst things we can do to people. Making it difficult for people to sleep at night, giving them all sorts of medicines that really predispose to delirium, like opioids, pain medicines. All sorts of things can contribute. And I won't spend much more time than that on this conversation, but there is a really good, if you're very interested in this topic, this reference by Joanne Wilson is a really great review still. It was published in 2020, and it really was kind of the state of the art in terms of our knowledge about delirium. So it's a great reference. Okay, so I hope that I've given you a little bit of a sneak peek at what it's like to be delirious and what it might look like from the outside, and in whom we might expect it. I'd now like to introduce to you the reasons that we care. Well, it's very interesting, but I'm going to talk about the ICU population, because remember, if we want to study delirium, it's the place where people are most often delirious. So I've spent a lot of time in ICUs over the last 10 years. And what we've learned is that people who are delirious are more likely to be mechanically ventilated, to be put on a breathing machine, and have longer durations on a breathing machine. They tend to have longer ICU lengths of stay and hospital lengths of stay. They, of course, by definition, will incur higher ICU and hospital costs. And the national annual costs estimated in 2007 to be due to delirium could, depending on what you include and what you don't include, somewhere between $4 to $16 billion in the US. So lots of money being spent in the healthcare system as a result of people being delirious. And I think I've already made the point to you with my video that patient and caregiver and hospital personnel, medical personnel suffering is great as a result of delirium. So, another thing that Hippocrates notes in his book is that delirium seems to be a very bad harbinger of something else. It's actually of death. And in fact, we do note that delirium is not just a little problem. It's a medical emergency. The fact that someone's delirious means something's terribly wrong. Just like in Joanne's case, it meant that she had a terrible infection throughout her body. And in as much as a terrible illness is very much associated with death in the hospital, it's very interesting because delirium in and of itself seems to also predict a greater likelihood of death in the year after somebody has a delirium. I'm talking about the ICU right now. It may not apply to all of the episodes of delirium that we see in the hospital, but certainly in the ICU. It does seem that the longer the episode of delirium that you have in the ICU, the greater the likelihood that you will die in the year after your ICU hospitalization, which is pretty sobering. And I think it's something, of course, we always want to say to the families of Joanne that, yes, she'll get better. This is just transient. But I think we have to be careful how we talk about it and not be too cavalier, because it isn't. It is a signal that not all is well with the individual. So long-term outcomes associated with delirium are also that people don't seem to do as well after they're discharged from the hospital. That new nursing home placement is much more common in those with delirium during their hospitalization. And some work that's actually featured in this graph here on the slide, that for those individuals in the intensive care unit who develop delirium, there is some evidence of cognitive loss that seems to be worse the longer that the delirium lasts. Not entirely clear if it's actually a direct cause of the delirium, but again, it may be a marker of whatever serious illness is going on is also responsible for cognitive loss over time. And here's something, I'm not going to go through the exact study because there's a lot of detail that's probably peripheral to this discussion, but it's important to summarize that a completely different study of a population living in the community in Finland, looking at the impact of delirium on the course of cognitive decline. Delirium seems quite independent of going to the hospital or anything else, that if you have episodes of delirium over the course of 10 years, and you're living in this community in Finland, that you tend to have a worse loss of cognition if you have delirium. So really supporting the work I was just showing you in the previous slide. This is a really, really important point, and this is where the delirium research community finally got some really good traction, because you can see that if we can prevent delirium, we might actually be preventing some cognitive decline from other conditions, such as those individuals who already have a pre-morbid cognitive impairment, say due to dementia. So this is an important question all of a sudden. It should have been important even with Joanne's story, but when we see ways that we may even improve dementia outcomes by preventing delirium, it becomes super important to address within our hospital systems. So how do we prevent? How do we treat? I'm not going to spend too much time on this, but I do want to show you some things that are very compelling. So the first things people always want to know is, like, do you have a drug to prevent it, right? We're always looking for a drug to prevent or a drug to treat. And here's a funny twist to my talk. One of the risk factors that we have actually noted early on in this work is that medicines like lorazepam, which you may know as Ativan, it's a sedative medicine, it's a benzodiazepine, and we use it in the intensive care unit. It absolutely seems to be, whether it causes delirium, I'm not sure, but it certainly is associated with delirium. So the more lorazepam that you use, the more likely people are going to get delirious. So we learned that early on. Instead of actually preventing delirium, it seems like sedative medicines may actually cause delirium. So too, midazolam, it's another sedating agent. And fentanyl, you probably know it because of all of it, the notoriety that fentanyl has these days. It's a drug that we've used for years in the intensive care setting for pain management. It's a great pain management strategy. But both of these medicines too seem to be associated with more delirium. This is a real conundrum for us, because for years we have thought of the most humane care in the ICU as being the sedated, comatose patient. In fact, I remember people saying, the only way that we can really do good things for people is to sedate them and put them into a coma, a medically assisted coma. Now, there may be some very specific cases and specific points during the critical illness that you have to sedate people deeply. I'm not arguing with that. But what this group of delirium interested intensive care doctors and psychiatrists and geriatricians and a whole bunch of and nurses and rehab therapists has really come around to showing is that actually this might not be so humane if you do it for longer than you absolutely need to. Because the first principle in medicine is that we want to do no harm. So what became really interesting to us in the early days of this work is that maybe there's a different way. Maybe we don't need to keep people sedated all the time in the ICU. Maybe we should decrease sedating drugs which are perhaps contributing to the delirium in the ICU, which has such long-lasting and bad effects. So our group and others piloted early approaches, a different approach to sedation in the intensive care unit. This was our very first patient who participated in this study, and he too gave us permission to use his photograph broadly. Mr. G.E., this is his first day in the ICU. Now, he came in about 12 hours before. He was very ill. He had a very severe pneumonia and had to be intubated. And so intubation meaning putting a tube down his throat so a breathing machine could help him breathe appropriately to save his life. And in so doing, he, of course, was given lots of sedating medicines, those same ones I was questioning. He was then, instead of being left on the stretcher like the gentleman I just showed you and kept in a deep coma, he was woken up progressively and such that he could stay alert and calm and awake. And in this case, he was not delirious when he woke up. He was actually pretty good. It took a little while for him to get comfortable with that tube in his throat because it's just not natural at all, but he was able to do so. And what's really nice about this is that he's able to interact with us, even though he can't talk because he has a tube down his throat, but he can actually interact by writing. And there we have many other tools in the ICU as well that we can use to interact with patients. So, you know, we have boards, all sorts of boards and things that people can use to answer questions with. But the nice thing is all of a sudden you can interact with him. And I'll come back to another really important thing that this allows us to do. Anyway, so we've really changed, and there really has been a change worldwide in the expectation of what we should be doing. Not everybody's following it. Not everybody is able to do it because it's a hard shift to make from that comatose patient to this awake and alert sitting up patient. Very different nursing care, very different approach, but it's really catching on and people are recognizing how important this is. This is, again, I'm not going to go through the details, but our group did a study looking at what the impacts of reducing sedation had on our delirium rates. And suffice it to say that reducing all of these drugs in the ICU does reduce the amount of delirium that those individuals who have less sedation have. So a clear association with the reduction in ICU sedation. Again, I don't know if it's just the drugs contributing to it. It may be that somebody's awake and alert and can interact with their environment. That's the big difference. But it really is a very important reason for continuing to try to have a different approach to ICU sedation. I think also the other thing is that in addition to being able to interact with their care providers, the patients, they can move around. It's much more humane in a way, at least patients say it's much more humane in that they're able to interact with others. And I think that it is really important for us to, as care providers, to remember, but maybe this is even really important for all of us as patients, because maybe we don't all have to go to the ICU with loved ones, God forbid, hopefully none of us do. But if you are in a situation where you have a loved one who has to be in a coma, medically induced coma, like the gentleman I showed you on the stretcher, then I think it's really important to remember some of the stories that we've heard. So, for example, Joanne, whom you've heard from already today, she also told me about how frustrating it was when she was in the ICU because she could hear the nursing staff or some of the bedside staff talking as if she were a, quote, bag of potatoes. So, of course, she looked like the man probably on the stretcher. She looked comatose. She looked out of it. And so people start talking all their personal business because they think that the person can't hear them. And yet, what we often hear from patients is when they're in this induced coma state, they can sort of hear what's going on. And God knows they may have all these other delusions that are going on, like Joanne did. And they misinterpret things, and it's very frightening. And I think it's very disrespectful of us to be doing that around patients because we don't know what they're hearing. So when I would take students into a bedside, if somebody was comatose, didn't matter to me, I would introduce myself to the patient. I would say, you're here at Johns Hopkins. This is how you came in. We're hoping to get you better. You seem, if that is what's going on, you seem really frightened, and we just want to reassure you you're safe, and, you know, a little update, a little orientation about where things are. You know, a lot of the residents thought that I was just dotty and sort of silly, and why would I do that? But it's because of stories like Joanne's But it also helps us model, really importantly, that we don't know what's going on and that we better offer all the support and kindness and softness that we can, just like Joanne told us. Speak gently, speak softly, reorientate, play nice music. Let's just assume that we don't know what's going on, and whatever we can reach out to the patient in whatever state they're in, that it's best to do that. So that's a little digression, but I think it's an important one. Beware the comatose patient. You don't know what's going on. And I think having patients alert and awake as best as we can manage in the ICU is a great advance, because it forces us to deal with people instead of bags of potatoes in bed. Okay, but you're probably going to say to me, yeah, oh, yeah. Okay, reduce sedation. But are there any drugs that can actually help prevent this or treat it? And believe me, we've been looking for the last 15 to 20 years, or 15 years, I guess. This is an old study, but basically, again, lots of trials trying to look at various kinds of ways that we might be able to prevent delirium or shorten the course once it occurs. Really, no agent can consistently prevent or treat delirium. But I did want to mention, because some of you may actually be familiar with our approach sometimes when people are as frightened as Joanne. As far as drugs to decrease that fearfulness in the midst of delusions like she was having about having this crystal and needing to get it somewhere and being beset by aliens and robots, I, as a psychiatrist, will prescribe antipsychotics for people who are biting and dangerous to staff and to themselves, and very distressed. And this has no FDA approval whatsoever. And I know, and I can tell you, because I've done a lot of the work and looking at the literature, they don't actually prevent delirium and they don't shorten the course. But I think it's still important to actually address people's suffering and try to make them feel a little bit more comfortable. And so drugs like haloperidol, olanzapine, or quetiapine have been used and are used pretty frequently by intensive care unit staff when people are delirious and that they seem to be quite distressed, or they're acting in a dangerous and combative kind of way like Joanne was. But the reason I'm telling you about this is it's just symptomatic treatment. We're not even absolutely sure that it does good things for people, but we all think it does in terms of calming them down and feeling a little bit more comfortable. But here's the problem with that. And this is certainly any of you who have loved ones who come home on medication lists, love you to think about this with your family doctor, your primary care provider. So in this one study of looking at people who came through the intensive care unit, this is an old study again too, done in 2016, about 11% of people were started on antipsychotics in the ICU as a result of a delirium, with the same rationale that I just gave you. 20% of that population went home on those antipsychotics. And this is really not really appropriate. That was a lot of patients who were continued that really don't have a good reason to be on those medicines long term. Those were just supposed to be started for symptomatic treatment in the midst of a delirium. So once those symptoms resolve, once somebody is no longer agitated, those medicines should go away. So it's really important for us as care providers to do a better job of stopping these medicines. But it's hard sometimes when people are still a little bit symptomatic and they're trying to shift to the next level of care. And it's really important to communicate with those care providers that these medicines should stop. And so I really would want to empower us as purveyors of care, but also those who actually get care, to be questioning whether people need to be on antipsychotics long term. Really not a great idea, unless there's some other reason for them to be prescribed. Okay, so those are my delirium takeaways. Do no harm, decrease sedation, get patients awake and alert if you can. And antipsychotics don't decrease the incidence, duration, or severity of delirium. But if you need them for distress, it might be indicated, but we need to stop them quickly and not keep people on them long term. Well, what can we do that isn't related to drugs? And this is where the big money is. So I'm going to start at the bottom of the list here. It's really important that we know that cognitive stimulation, interaction with people, getting people to think, getting people to do puzzles, to sort of calculate things, to just talk about things with their family members, really important. Frequent reorientation, making sure people know how they got to the hospital, just like I was saying with a comatose patient, you're explaining how you got here, what happened. Frequently reorienting people, giving them their hearing aids so they can hear. And I didn't put it on the slide, but so too, making sure people have their glasses so they can read and they can see. Ensuring that they're eating well and that their fluid intake is appropriate in the hospital. Very important. Reducing medicines that increase delirium. There's a whole host of medicines that probably can make delirium worse, and that we should be good stewards in the hospital and make sure that we're thinking carefully about all the meds somebody's on. Improving people's sleep. This is something that we're terrible at in the hospital. We have to work all night. We make everybody pay by keeping them up all night because we're so noisy. So lots of initiatives that trying to calm things down, switch lights out, keep procedures even in the ICU to the daylight hours and not overnight. Big efforts have been done on this. But here in blue is really the intervention on its own that's probably the most powerful that we have in our armamentarium. And it's early rehabilitation, which actually includes cognitive stimulation, but really importantly, physical mobility. So getting people to move is probably one of the most important things we can do. And so the corollary is just letting people sleep throughout the day in the hospital is not a good idea. It's really bad for their brain, really bad for their body. So getting people awake and alert during the day, getting them to sleep at night, very important. So let me show you a little bit about the early rehabilitation. So this is Mr. GE again, our first patient whom we did the sedation reduction on. This is day one. He's actually using a walker to walk around our crowded little ICU at the time. And here, one of the nurses has his breathing machine on a little trolley so he can walk around. And this is early rehabilitation, early mobilization. This is day one, and he came in with a terrible pneumonia into the ICU. This is what he says about it when we asked him. We said, how do you feel about bed rest, keeping you in bed? Would you prefer to be in bed? And he said, no, it's unbearable. You lose your dignity when you're in bed all the time. And what about walking on the ventilator like this? And he said later of it that it was wonderful just to be able to walk, that it was very enjoyable. And when we asked him if we should keep going with this intervention, he said, yes, you should get them, which he meant us as in patients in the ICU, up moving as soon as possible. The sooner the better. It's really funny because he was absolutely right. There is something in what he said that was actually quite portentous. So what we actually learned is from our work and others' work on early mobility and early rehabilitation is that it not only prevents delirium from occurring, it actually reduces the length of the delirium. If you can get people up and moving, even when they're delirious, trying to get them up and moving, it's very important. It improves their physical function overall, and it decreases length of stay in both the ICU as well as the hospital, and improves physical function outside in the year after an ICU stay. But just like Mr. GE was saying, the timing of mobility is very important. So early rehabilitation, getting people out of bed early, is much more beneficial than waiting 3, 5, 6, 7 days before getting them out of bed. It's So again, it's a sea change in terms of how we act and how we want to care for patients within the hospital. Very different. No longer comatose, no longer staying in bed for days on end. In fact, the worst thing you can do for people is leave them in bed. So sedation practices matter, right? Because you can't mobilize somebody who's a sack of potatoes on a stretcher. You need to be getting them up. You need to have them awake and alert to interact with you. And then just my one final little kind of public broadcast announcement. Mobility really matters, not who delivers it. So if you have your grandma or your auntie or your uncle and they're in the hospital and they're on a unit, they're not even in the ICU, this is still an important message for them as well. Please, please, please think about ways to get them interactive, to be awake and engaged during the day, various kinds of cognitive measures, but as well as mobility measures. And if it's safe to mobilize them, it's always best to check with the nursing staff and to find out how stable and steady people are. But if they are stable and steady on their feet, make sure they walk around the unit, get them out of their room, get them up and moving. Really important. Mobility matters, not who delivers it. This is, again, just a reminder that we've actually been looking at all these interventions, and what's most powerful are multi-component bundles. So where you're putting all of this together. And from what we can see in both surgical as well as medical settings, we can reduce delirium that occurs in the hospital by about 1/3. That's 33%. If we actually do these multi-component bundles. And that means not having people completely sedated for too long, only as absolutely as long as needed, getting them up and walking as soon as possible, or getting them up and mobilizing in some various ways. All those things I talked about, the hydration, the orientation, the sleep, all of those things put together, we can probably reduce delirium by about 1/3. And maybe that doesn't sound like that much because there's still 2/3 of people who are going to get delirious, even with best practices. But 1/3's a lot when you think about that community in Vantaa, Finland. If we reduce by 1/3, it may well mean that we've reduced the accelerated decline in cognition in the community quite considerably by 1/3. That's the hope anyway. So I just wanted to show you what some of these non-pharmacologic, non-drug interventions look like in an ICU that's practicing these multi-component bundles. And so this comes from some colleagues in Japan who went back and implemented a lot of the same changes that we had been doing at Hopkins. Here's a patient reading the newspaper. You can see that he's on a breathing machine. He's intubated, but he's awake and he's alert and he's interacting with his environment by reading the newspaper, by enjoying a difficult Sudoku puzzle, by walking outside of the ICU. This is actually a colleague here at McMaster University, Michelle Coe. She's a physical therapist and she's a professor within the School of Rehab Medicine. And she actually came and worked with us at Hopkins for a few years. And this is her walking a patient. She's actually helped us in many, many ways do some of this work on the benefits of early mobility and rehabilitation. Walking outside of the hospital for sunshine therapy. What about if you can't get somebody out of bed? Well, there are in-bed cycles, as they're called, and this is basically a bicycle that you pedal and you can stay in bed. Actually, a really nice review just came out a couple of weeks ago that has reviewed all the literature on the use of the in-bed cycle. Really helpful for decreasing for preventing delirium, for decreasing the length of a delirium episode, as well as just overall better for physical functioning. So, and we do have these. We have these at Hamilton Health Sciences within the ICUs here. So really interesting kinds of innovations that people have been coming up with. We have a little play on words. Again, Michelle Coe's work at Hopkins when she was a fellow. And hydrotherapy, we didn't have this at Hopkins. This comes from a German ICU where they have a pool where they get people into the pool and get them moving, and found an easier way to actually encourage mobility. So some of the creative and inventive ways that people have been trying to increase mobility and really increase cognitive and physical outcomes as a whole after critical illness. So, in summary, I hope I've convinced you that delirium is a really important condition to recognize, to prevent, and if it's occurring, to treat. It's common, it's expensive, it's associated with all sorts of bad outcomes, and it really causes a lot of suffering. As far as prevention and treatment, we don't really have any evidence yet that drugs can actually be used to prevent or treat it. But we do have evidence that decreasing sedation is for the good in terms of helping people not develop delirium during critical illness in the ICU. As well, we know that increasing early mobilization of brain and body is probably one of the most powerful things we can do for people. And so I hope that I have intrigued you with this and that you're thinking about ways that you can be helpful to others in your life, or you yourself can get more activity in this way, because it seems to be really powerful. And finally, I just wanted to show you if you were to scan the barcode at the bottom, this is a website that a wonderful colleague of mine here in my department at McMaster University has, his name is Dr. Anthony Levinson. He's put together this very brief delirium module, educational module. You can, again, sort of review some of the basic concepts and understand a little bit more about delirium. If you'd like to do that, it's free, and you can just sign in to Anthony's website that's listed here, and perhaps we can send that out to people too. Finally, I want to thank you for your attention, and I welcome any questions that you have.